Nurses are our eyes and ears in the unit, and any good ICU doc or ER doc knows that.
Hi, this is Nicole Kupchik, and welcome to 10 Minute Tidbits. Today, I'm here with...
Nick Johnson. I'm an emergency physician and critical care doc at Harborview in Seattle.
And we know a ton of people that are commonalities between the two of us.
Too many.
Yes, and so it's been kind of fun, but I'm so excited. So Nick's going to join me for quite a few episodes, and today we're going to chat about the nurse-doctor interaction at the bedside.
Yeah, I think it's one of the best topics we can talk about here because we've both seen both sides of it, and both have worked in a place where it goes particularly well.
Yeah. Well, one of the crazy things, I'll never forget, it was back in like 2003, 2004, I was asked to kind of lead this project where nurses would present to the team at the bedside. And when I initially put this out to the physicians, they were like, how much time is it going to take? I'm not really sure about that. But then once we did it a few times, the same physicians came back and said, actually it was really good. We liked it.
And now we wouldn't have it any other way.
Yeah, which is pretty cool thing. So, all right. So how many of you out there are kind of presenting to the physicians or providers, PAs, NPs on rounds? Are you guys doing that out there? So you've worked with that model.
Yeah, that's pretty much our exclusive model in the ICUs at Harborview now. It works well because most of the time the residents or the team will pre-round and evaluate the patients in the morning, and by the time we actually make it around to see the patients, all of the data and plan for the day has changed, and the only person who really knows that plan is the bedside nurse.
Yeah, well, and I think it's kind of a crazy thing to think that we would have providers or physicians around and never talk to the nurse. And that happened, I will tell you, I've been 26 years in, right? And it happened for about the first decade of my career. And that just needed to change because nurses are at the bedside 24/7. Right. Okay, so what are some things that you would say would be a major positive that you would like to see as an interaction or feedback from nurses about the patient?
So I think first having some structure. So the thing that I think worked really well at Harborview was that there was an agreed upon structured rounding practice that we would have where the nurses would present overnight events and kind of the most up-to-date data. The physician team talks about the assessment and plan, then we come together and we do a written and verbal plan of the day that we share, and that sheet stays with the nurse at the bedside so that we're all on the same page.
Yeah.
So structure is, I think, the first most important thing.
Yeah, and how many of you out there are creating or establishing a very discrete plan of the day and being very purposeful about it? And can the family see it? Can the patient see it? Because I think that's one of the things that's, to kind of get everyone on the same page is that the family, patient, team, all is on the same page.
Absolutely.
Right.
Yeah, and I think the key pitfall on rounds is for all groups feeling like they need to talk indefinitely and really lets things drag on. So having that structure keeps you focused on the task, you get all the pertinent data communicated, and you walk away feeling like you're on the same page about the plan.
Yeah. Okay, let's say maybe there's a patient that we can't really decide on care. How do you feel about nurses speaking up and just saying like I disagree with this? Or let's get how you feel, but I would know, how do you think like your colleagues feel?
So I think it's really important for that to happen, and a lot of times it's one of the most important safety checks that we have in the ICU or in the ED. When there's a safety concern, using those words explicitly and saying, I'm worried about safety, here are my concerns, and lay it out, that really perks my ears up as an ICU attending, and I'm sure it would for a lot of people. I think having those open lines of communication about what you think is going on with the patient, what you're worried about. Nurses are our eyes and ears in the unit, and any good ICU doc or ER doc knows that. And so you really have to be in tune, especially with your experienced nurses, about when those concerns are brought up. So personally, I feel like anytime I'm hearing about a safety concern, I'm at that patient's bedside and pretty quickly, and I would imagine that's probably true for most people.
Yeah, so anyway, okay, so let's ask now, what do nurses do that you would say is not the best use of time on rounds?
Yeah. So I'm kind of going back to my days as a resident and a fellow, and I think one of the most important things is it can be hard as a bedside ICU nurse, especially where you have one really sick patient, realizing what else that team has to do that day. And so clustering the non-emergent stuff is really helpful. So if you've got a laundry list of tasks, rather than kind of paging out every couple hours, can you renew this order, renew that order?
Yeah.
Trying to get all that stuff done at once so the team can have some mental bandwidth to then move on and think about the
Got
next
it.
person. Because most of the time we're juggling a whole bunch of tasks all throughout the day. So I think the kind of slow trickle of pages, just like I'm sure the slow trickle of orders drives nurses crazy.
Yeah, it does. Let's be honest, nurses, we will agree with you.
So whenever you can do to cluster those things on either end to sort of allow workflow to be a little bit more efficient.
Okay. All right. And then how do you manage, like, I'm sure you've seen this before, the nurse or maybe the resident that drones on and on and on and on?
I sometimes will just kind of call it back and say, let's just focus on this issue, or let's move on to the next issue and we can talk about this later.
Yeah.
I think one that comes up a lot of times on ICU rounds especially is goals of care.
Yes.
And a lot of times our nurses are working to be a really good advocate for patients and families and want to have those discussions right there on rounds, when a lot of times those discussions should probably happen later in a more calm environment with family sitting in a conference room. And so that's one situation where I'll sometimes say, I agree with you, this is a really important point, but we need to go sit down and talk about this with the family in a little bit more detail, not on rounds.
Oh, yeah, I completely agree. And I think that's one of the things at the bedside from a nurse's perspective that we get so frustrated with. It's just feeling like, where are we going with this patient? We know what the endpoint's going to be. Why are we doing all this extravagant care? And so I think that's a really good point of just saying, or maybe even a nurse could say to the team, I think we need a family conference to sit down and talk about goals of care.
That's a great way to frame it. I think let's just put it on the agenda, but maybe we don't need to rehash a conversation that we had at length yesterday or that we're going to have later today on rounds.
Yeah, I think that's a really good point. And I'm sure too, that's one of the frustrating things from a provider physician standpoint is that you all work stretches in a row where nurses a lot of times might do 2 or 3 in a row and then we're off. And that, I'm sure that continuity of care can be quite challenging.
Yeah, I think sometimes there are issues getting up to speed on both ends. We as attendings work a 1-week stretch, but our fellows work a month, so sometimes they have a lot more perspective on previous conversations. Yeah. And similarly with nurses who work 2 or 3 day stretches and we work a week stretch, sometimes they won't be aware of a goals of care conversation that we had 4 or 5 days ago.
Yeah.
And we have to kind of rehash some of those things sometimes. But I think that's all part of making sure that your entire team's on the same page.
Yeah, and I guess one of the wishes I have is I just wish the chart told the story a little better. Right. I just EHRs. I know, don't even get me started. But I just think that would be such an enhancement to the bedside is if the EHR actually told the story.
Yeah, one of the things that we started doing at Harborview a few years ago was consistently documenting family meetings and actually having a family meeting note template. And I feel like that's helped with this issue a lot. It requires an extra note some days, but having that somewhere in the record that's searchable and easily found by all members of the team sometimes alleviates a little bit of that moral distress that comes from just not knowing when the last conversation was.
Oh, I love that. Or any of you doing that out there, maybe where you'd have a purposeful note about a family conference or goals of care. That's pretty fabulous. So, all right, any other parting words for nurses out there?
No, I think the one thing that I really like to hear is when I get a phone call about some level of concern. Usually by the time it reaches me as the attending, it's a high level of concern. Really hearing not only what the concern is, the abnormal lab value or the abnormal test or vital sign, but what the nurse's assessment and proposed plan is, because that way I know that we're on the same page. And I really do want to hear those things. A lot of our nurses are super experienced, have a lot to bring to the table in terms of clinical knowledge and depth, and coming with a plan is usually really helpful, both in terms of workflow and also making sure that we're on the same page.
I like that. Now, how many of you want to clone him and work with him, right? So anyway, I love it. So, I just want to thank you. I think this is, and if any questions you guys have, please put them down in the notes or in the comment section. We'd love to hear from you, and I'll circle back with Dr. Nick Johnson and get some answers for you. So, all right. Well, thanks for that. It's pretty awesome. So I'm Nicole Kupchik. This is
Nick Johnson.
And this is 10 Minute Tidbits.